Pop Health Podcast is a public service of 24-hour home care. Hello, everyone, and welcome to another episode of Pop Health Podcast. This is Gavin Ward, host of Pop Health Podcast. In today's episode, I had the opportunity to sit down with David Lubarsky. David is the CEO of UC Davis Health. Now, some of you may be wondering, UC Davis Health, where is that? Well, it's actually in the Greater Sacramento area in Northern California, and David had the exact same question when he was reached out to by a recruiter while he was leading a health system out in Florida. So David went on that jaunt out to California, and he's now been serving there for 2 years. UC Davis Health was actually in the news recently, and some of you may be like, oh yeah, was that the organization that helped serve that COVID patient? The answer is yes. So the very first community spread case of COVID-19 was treated at UC Davis Health. And David shares about that story, lessons learned, as well as some other information on UC Davis, including how it was able to create one of the very first drugs to treat Ebola, which now can also be used in the treatment of COVID-19. We hope you enjoyed today's episode. Feel free to check us out and see other episodes on YouTube or hear us on pophealthpodcast.com, Apple Music, Spotify, and Stitcher as well. Thanks, everybody. Enjoy the show. So, David, share with us something about you that might surprise the audience, maybe something outside of the workplace.
Well, I don't know if it's going to surprise people because so many physicians are musicians, but I used to be a classically trained pianist, failed in my tryout to play one summer with the New York Philharmonic, and decided to go to a combined pre-med medical school program because I just wasn't a good enough pianist.
Do you still play today, or?
I do. I still have, my parents were nice enough to help fund a Steinway when I graduated from medical school.
Yeah.
And I still have that. And I studied actually all the way until I was in my 30s. And then my academic career sort of took up all my time. Yeah.
So is the Steinway like completely protected? I know like you can't even like, I've been by one before. And it's like, don't touch.
No, it's meant to be played. And one of the most fun times I ever had was when, as I was graduating medical school and then doing my residency at NYU, the giant Steinway Gallery is on 57th Street in New York, where I was doing my residency. And I would go there every day, and I would play 2 hours a day, trying out every single piano that they had in stock before I picked the one that I currently own.
Wow, that is great. So at home, is it uncovered then?
Oh yes. It's out there ready to be played. I don't sit down more than once a week anymore, but at least it's there.
Yeah, well, that's great. So you mentioned med school, but that wasn't your original plan. Maybe give us a background on your childhood and where you grew up.
Sure. Well, spent my early years growing up across the street from Yankee Stadium, going to sleep to the sounds of the ball game, playing Little League in the shadows of what is now a parking lot, but used to be the shadows of the stadium on a ball field. And then in the suburbs, and had a pretty really charmed life, and was very lucky. Had tremendous support from my family, and my best friend's grandfather was my family physician and the inspiration for me becoming a physician.
Okay. Awesome. So you grew up in New York. I'm trying to catch the New York accent. I don't know if it's there. Do you have it?
Only on rare certain words that, are ingrained, but pretty much no. I went to undergraduate in medical school at Washington University in St. Louis, and it was a pretty bland dialect out in the middle of the country, and I sort of lost my New York accent.
Okay. That makes sense. So you go to school, do your undergrad out there in St. Louis, and I know just with a little bit of your background, you spent a lot of your time in the last couple decades in Florida. How did you end up getting all the way down to Florida?
I like the warm weather. And again, little known fact, so I don't know if you know what Raynaud's disease is, but it actually causes your hands to kind of get very, very cold in slightly cold weather and vasoconstrict. And so I sort of had that, and I didn't know that, and I realized that I would be much better off. I blame that for why I didn't make the piano tryout, by the way. Not true, but it would be convenient. But so I ended up going to Duke actually for 14 years and becoming a tenured professor there before heading all the way down to Miami. But I really enjoyed the Southeast tremendously. I liked the weather, and the humidity didn't bother me.
Okay, so you've done New York, Missouri, East Coast, Southeast, and then what inspired the move to come out west?
Well, sometimes in a trajectory in a career, you make a decision that to find the best opportunity, you may have to look outside of your own backyard. And that's the decision that I made, actually, that as my youngest child was graduating from high school, I decided that I needed to actually do something that would be truly meaningful in terms of making the world a better place. And I had done as much as I was going to do at the University of Miami. Loved my career there, but it was time for a different environment. And so actually a headhunter called me up and said they knew of me and that this was the perfect job for someone like me. Okay. And I was like, okay, I'll take a look. That's the way it was.
Interesting. Okay. Because UC Davis is, for folks that are far away, it's, more not in necessarily the bigger cities that the West Coast is known, right?
Well, if I may, so when the headhunter did call me up and they said, we've got this great job at UC Davis for you, that we want you to apply for. And I said to them, well, that's nice. I don't even know where Davis is.
Yeah.
And then they said, don't worry, the healthcare system's actually in Sacramento. Yes. Now, I had memorized all the capitals, right, of the United States of America back when I was in like second or third grade, right, because that's what you did back then. Yeah. And I knew that Sacramento was the capital of California, but I could have never even put my finger on it on a map. I'd been to California 30 times, but only to the coastal cities, right?
Right. Yeah. I mean, I grew up in California and not until, I just turned 40, but I think in my 30s is when I realized, Davis is in Sacramento. I actually played an ultimate Frisbee tournament at the university at UC Davis as a kid, but I didn't even realize that the health portion of UC Davis is really based in Sacramento. So you go to Sacramento. Why was it the perfect job for you?
The reason it was a perfect job is that the organization decided that they were going to eliminate the silos and the barriers between our healthcare delivery arm, which was primarily our hospital, and the academic entity, the School of Medicine, and its great research and educational enterprise, which was the School of Medicine and the School of Nursing. And while they worked together and they were on the same campus, they really didn't act as a single unified entity doing everything as if there was truly only one entity. And so the idea of integrating the clinics and the hospital, the schools and the research, well, that's actually kind of what I was doing in Miami. I was the Chief Systems Integration Officer, but this was writ large, and it was with a top 50 organization from stem to stern, top 50 kids hospital, top 50 adult hospital, top 50 medical school, top 50 graduate nursing school. I was like, oh, wow. All of these parts, and yet they are not greater yet than the sum of the parts because, well, I hadn't really heard of UC Davis when I was in Miami. So I took that as a great challenge to bring the world the information about how great UC Davis really was, both and even and also to forge ties and build bridges and make the causeway between Sacramento and Davis a real bridge for research and educational enterprise. And again, just a great opportunity to build something important for the world.
Awesome. So was there anybody you had to convince with you to take the journey with you, or did you come out solo?
I failed sort of in my attempt to do that, and ended up getting divorced. Actually, it was part of the move, not entirely related to that, but it was a time for something different. And I'm still on great terms with my ex-wife. She still lives in Miami, and my other kids, they're all in school or out in the job world, living where they live.
Okay, got it. So before we get into what you're doing at UC Davis, I have to ask. You've been in different parts of the country. Are you into sports at all?
I am.
What are your loyalties like? You mentioned Yankee Stadium, so.
Yeah, diehard Yankees fan from when I was, 0, right? And I used to be able to, I had a very good memory back when I was a little kid, and I literally could tell you every statistic of every single player on the Yankees without exception, right? No matter, right? And then moving along, when I got to Duke, I became a real Duke basketball fan. Yeah, so that still sticks with me. But now I'm in Sacramento. I live right near the Kings stadiums, and I have become a real Kings fan. It's not as easy as being a Duke basketball fan, but it's a lot of fun.
I hear that. I was in Sacramento, I was saying a few months ago. We had my day job. We had our annual meeting up in Sacramento at the hotel right on campus of the stadium. I forget what the name of the hotel is. And the former mayor, Kevin Johnson, was a guest speaker, so we got to meet him. But I know what you mean about it might be more challenging and tough years. Duke usually has a lot of good years. Sacramento, yeah.
Well, you know what? There's the thing is that when the Kings win, it's something to celebrate.
Yeah. It's not routine. It's something out of the ordinary. Cool. So you get to UC Davis, and you kind of gave an overview of all the different silos. Maybe just briefly, this might be a little bit of a recap, but can you tell the audience about UC Davis Health? What is that? What is UC Davis Health?
Right. So UC Davis Health is the combination of all the things we do basically on the Sacramento campus, plus our basic science divisions that live in Davis, actually. So we have a 625-bed level 1 trauma center hospital that most people know about. We have 70 different clinic locations around the region. We are a partner in many FQHCs, that is underserved community clinics around the entire city. And that all put together is sort of the health delivery system. And then there's our physicians. We have 1,000 physicians. We have 1,000 physician trainees. We have 1,000 students in training before they become physicians in training. And so all told, we have a little over 14,000 people, a little more than that, that currently work for UC Davis Health, delivering our education, research, and clinical enterprise.
That's great. And friendly reminder, folks, Sacramento area.
Sacramento, right, and a $3.5 billion a year budget. It's a big organization.
So you've been there since 2018, and one of the things that attracted you was the opportunity to integrate everything. How's that going so far?
It is going better than I could have possibly hoped for. And by putting ourselves together, by becoming a single entity with a single strategy, with a single execution arm, with joint leadership decision making across all the different entities that I've discussed, we've managed to have a growth trajectory that's maybe among the best in the United States of America. We've grown 1% a month since I arrived. So we've grown 24% in 24 months.
Okay.
And that's just because there were all of these opportunities that if we could all just sort of work together and pull the wagon in the same direction, became really easy to realize. And so actually again, kudos to Chancellor May, my boss, who, actually created my role, the idea of there being a single academic physician leader for the entire enterprise. It didn't exist prior to my hire. And his vision for how this should work, hopefully, is meeting his expectations. I know that we're doing a lot more collaboration with the undergraduate campus in terms of both education and research now as well, which again, will just simply elevate the reputation of our organization.
Yeah,
and serve people better. All right, that's always the thing: patients and the future health of the world.
Yeah, no, absolutely. So speaking of health and the world, we're recording this in the summer of 2020. Obviously, COVID-19 pandemic. You recently published an article about the first 6 months of what you've learned. Can you tell us briefly, like, one thing that's in that article that people may not know about is UC Davis took on the very first case of COVID-19 community spread. And you talked about putting UC Davis on the map when you came to UC Davis. And obviously this put Davis on the map. Tell us about that experience.
Right. Well, so I was hoping we would never see a community spread case, of course, like everybody. And what we ran into was very fascinating from day one. The level of sort of discoordination present at the federal level. As soon as we had seen one COVID-19 patient previously from the Diamond Princess. And so we sort of knew what it looked like. And when this patient came in from the community, after a little bit, we said, meaning in an hour or two, we realized, wow, this looks like COVID-19, but they can't have COVID-19 because we traced everything that we can. They don't have any of the criteria. And so we tried to get the person tested for COVID-19. We could not get them tested because the testing algorithms said, well, if you don't have any of these risk factors, you can't have it. And we're like, it meant that they could never have tested a community-acquired spread. That was the way the system worked. It was crazy. And we actually had to go toe-to-toe with people who didn't want to do the testing and eventually got the patient tested. And the rest is sort of history. We learned a ton around exposure and personal protective equipment and how to best communicate with our staff and our patients in order to make them feel safe. And boy, we learned that in a heartbeat.
Yeah, no, I bet. So a few other follow-up questions on that. One thing you referenced in your article was strategic testing. Can you explain what that means?
Sure. And first of all, it'd be great if we could all just get testing the way we get a pregnancy test, right? Go to the drugstore, pick something up, know in 5 minutes, right? But we don't have that. And we don't have total, universal, and ready, equitable access to testing yet. And so we have to use testing where it will actually most likely influence the trajectory of the pandemic. And so that means we have to pick and choose. As a matter of fact, California came out with its tiered testing strategy, which is very similar to actually what I proposed in another article about 2.5, 3 months ago. And the whole idea here is if you are likely to be someone who is going to contract COVID-19 because of your exposures, or that you are at risk of spreading it to many people because of your public-facing job, so therefore you need to be tested if there's any suspicion at all. That's really got to be the focus. And plus, there's a integral link between the availability of PPE and the diagnosis of COVID-19. When we started out and it was so hard to get testing, we would have 30 or 40 people in the hospital and we would be burning lots of PPE on every single patient because we didn't have ready, easily accessible tests. By doing testing of hospital admissions, you immediately know if you need to continue that level of quarantine and careful care to protect yourself versus treating them like a regular hospital patient. All very important for the safety of the staff, the safety of other patients, and to conserve PPE for those times when we need it, when someone does have COVID-19.
Yeah, that's great. Great response, great details. So with COVID, of course, a lot of transition. Most of the audience will know the transition to telehealth. You talked about telehealth in your article. What was the transition like for your system?
So when I first got to UC Davis, one of the things I wanted to do was to really promote building a virtual hospital and really promoting telehealth. And I set out to do this, and I actually invested a fair amount of UC Davis Health's resources in building up that capability before COVID came along. But it was a trial and a struggle. And my goal for last year was just to get 1% of the patients' outpatient visits onto a virtual platform. And although I did all sorts of things to try and promote that, it actually took two things. One was the fact that patients were scared to come to us, and we weren't all that anxious to have patients show up in our waiting room either. So all of a sudden, patients and physicians and nurses were all on the same page. And then we added the fact that the federal government finally saw fit to follow California's footsteps and make telehealth actually reimbursable for Medicare, which meant that, okay, funding and self-interest all came together, and we went in 3 weeks from less than 1% to 50% video visits. It's amazing. Wow. It was amazing.
So because one of the things I've asked guests in the past is the adoption of telehealth, even if it's you can generate a sustainable business, will the patients be willing to accept telehealth? And it sounds like you were able to accomplish both very quickly. Are you still getting a good amount of resistance on the patient side to telehealth?
It's evened out. So it went to 50% of a reduced number. A lot of people self-selected themselves out early in the COVID. Now that everybody is back and our clinics are running full tilt, we're still running about 15 to 20% virtual visits. Okay. As it turns out that for many patients, it's economical. They don't have to take their kid out of school. They don't have to take a day off from work. They don't have to spend $30 on gasoline to get to us. They don't have to spend, because we draw people from all over the area. And so if we can safely and completely deliver care into a patient's living room instead of making them come to our waiting room, wow, it's a win-win-win for everyone.
Yeah, that I agreed. Now you mentioned Medicare, the federal government came on board. What about the other clients or payers of UC Davis, the private insurance companies, Medi-Cal? Is there reimbursement there as well, or is that still something you're working through?
Yeah, no, just earlier, I guess about a year ago, the state legislature made it mandatory to have parity payments for telehealth. And so that actually was prescient, and it paved the way for us to really do the right thing.
Oh, that's great. Awesome. So COVID fatigue, doing podcasts, one of the things for me is I didn't want every episode to be about COVID. But it's relevant, right? It's the reality of what we deal with. And while this episode isn't specific about COVID, we wanted to touch base because you're an expert on it. So can you tell us a little bit about COVID fatigue and what that might mean for your staff, but also for patients?
Right. Well, so I'm an unwilling expert, as we all are these days, right? But I do try and read as much as humanly possible so that as I help to steer the organization, I am really doing it with some intimate knowledge as an academic physician.
Yeah.
And I'm tired of reading about it. And I'm sure everybody is tired of hearing about it. But the problem is that you have to have perseverance right now. You have to have resilience. You have to say, this could be with us for a year or two. Because even if we get a vaccine, to get it out to 200 million people to create the herd immunity that we need to, it's not going to happen overnight, no matter what pre-investment the federal government makes. And so along those lines, having psychological support from your loved ones, that as we talk about social distancing, that's the wrong word. Physical distancing, social connections is what will help us get through the crisis. A knowledge that your workplace is safe and concerned with your safety. And so our frontline workers, I hope, know that nothing other than the patient's health, nothing and is more important than their health and their safety as they come and put themselves on the front lines of care and put themselves at risk. I think that helps, but even then it adds tremendous stress and there's tremendous burnout. And when I first got here, we appointed one of the first chief wellness officers, whose job is about creating support services for frontline healthcare workers. And he is a psychiatrist, Dr. Peter Yellowlees, has been instrumental in, along with our psychiatry chair, Dr. Helen Kales, in creating programs to be incredibly supportive of our frontline healthcare workers to prevent that burnout. And the stress, there's a lot of stress because you're exposed, you're going home to your loved ones, maybe your kids, maybe your grandma, should I see them? I mean, it's tiring. It's very tiring.
So one thing I see out there in the media, sometimes prominent people, is them saying, oh, this COVID thing's not a big deal, it's overblown. Is there any short and succinct response that you think could compel them to reconsider? I'm trying to think.
I'm not allowed to use curse words, right? But I would only say this, is that anybody who says that should come to my intensive care unit today, and they will see, sadly, more patients than we'd like to see struggling to catch a breath, to try and make it through, or to talk to some of the people who maybe they're not critically ill, but they have lingering symptoms for weeks on end after the supposed recovery from this virus. The numbers are not made up. The deaths are not fictitious. The success of masking and physical distancing are known. And anybody who says it differently is living in the state of denial, not in the state of California.
Yeah, no, well said. So you mentioned earlier that your clinics are open. 15 to 20% of the visits are still being conducted via telehealth, which is good. What about elective surgeries? Now that some people are calling it the second wave, some people are calling it still part of the first wave. It's getting bad. It's bad. Are elective surgeries happening right now?
Well, I think unfortunately that word elective is probably the wrong word.
Yeah.
The only elective work that I know about in healthcare is cosmetic work, okay? Or some minor thing like, my knee's a little tweaky and maybe I want to get an arthroscope to see. But honestly, and orthopedists don't get angry at me, I'm not sure that's elective either. At UC Davis, we basically, we are a tertiary quaternary center. We take care of people who have cancer, who have trauma, and who need brain surgery, right? Well, if you have brain cancer, it's not elective. You may be able to move it from Monday to Tuesday, but it's not elective. A mammography is not elective. You may not need to get it this month. You can't wait 2 years till COVID is gone and go without your mammogram. You can't wait 2 years when you're 2 years old not to get your vaccinations that will protect you if you go back to school. These are not elective things. And so we have to do everything humanly possible to change that dialogue, because people have begun to think that way. Oh, I have an option to come in. But really, your ongoing health is not an option. And one of the most startling facts that people don't know is that, we saw a marked increase in the number of deaths early in the pandemic in March and April and May. But only 70% of those excess deaths were due to COVID. The other 30% were due to the fact that people were not seeking care for their strokes and their heart attacks, and they suffered fatal events at home. And we can't allow that to continue. And we're just going to create another pandemic when people stop getting their measles vaccines. Yeah. So we need to keep healthcare open, but we need to do it in a smart way. We need to fix the supply chain. We need some federal direction to plug the holes in the supply chain so PPE is available to all the frontline workers and the patients who visit them so they can get that needed care.
Yeah, well said, well said. So you mentioned federal government support. What about the community? How can, let me backtrack. When COVID first broke out, you heard stories of like free, food dropped off for first responders and for healthcare workers. If people have resources, money, time, what's the best way they can help UC Davis?
Well, first of all, I want to thank the hundreds of donors and food shops who did exactly what you talk about, and the young adults who came out and chalk painted our sidewalk. And it really makes a difference to our healthcare workers that people recognize, everybody from environmental services up through the exec suite and all the doctors and nurses and respiratory therapists in between. We really appreciate knowing that the public knows that we are putting ourselves at risk and we are doing this for the sake of our community. And so just knowing that and just keeping up, honestly, the donations aren't about the money. It's really about that sense that we're in this together. And the one thing the community can really do is to speak up when people start saying things like masks aren't necessary. Masks are necessary so that we can continue to do our job a little bit less than we're doing it. Stop getting together with 20 of your best friends in your backyard. That's how you can best support UC Davis. Get a flu vaccine. You say, why? Why should I get a flu vaccine? What's that got to do with COVID? Well, because come the winter, right, we usually see a ton of hospital admissions related to the flu. Yeah. We're not going to have room this year. Get your flu vaccine. That's the best way to make us take better and allow us to take better care of you, our community.
Yeah, no, great advice, and I agree with you, David, and listeners. I have a close family member. I won't name this person, but they believed in the myths of how you can get sick and catch the flu from the flu vaccine and things like that. And there's no science really behind that. So just agree with you, David. One last question. You mentioned there's not going to be room if a flu pandemic hits on top of the coronavirus pandemic. So I've heard stories about some county hospitals receiving military support. may I ask you, if UC Davis got full, what happens next? Do we deny patients? Do we have to reroute if there's other available? Does the military come in? Do you mind me asking about that?
No, I think that we've been very closely allied with the California Hospital Association, the California Medical Association, policy and planning for the California Health and Human Services Department, and close alliance with the California Department of Public Health and the Office of Emergency Services for the state. All the health systems are, in fact, this morning we had such a phone call. We are constantly doing surge planning. At both the city, county, state levels. We are constantly level setting and figuring out how we might load balance if any one area got overwhelmed. And if it really does get to that, we have surge plans. The state actually mandates that. UC Davis plays its part. We're the largest ICU care provider in the region. And so we are able to, we have plans to flex up from 84 adult ICU beds to 200 if we have to.
Wow.
So we're ready. And we're ready to serve the community. We don't want to get there, though, because the care that we're going to be delivering, it really won't be in our ICUs. It'll be makeshift, and it'll be converted spaces, and we don't want to get there. We want to flatten the curve again, keep it to a dull roar, wear our masks, be careful with whom we associate, and be able to go about our lives for the next year while we look for a vaccine. That's the answer to the whole problem. But I see far too many people who are deniers, and that will get us in trouble.
Yeah, no, good points, good reminders, David, and hopefully our audience is on board. And please share with your friends and family. David, as we end the show today, how can folks keep up to what you and UC Davis are up to?
Honestly, so I have a Twitter account, and we'll let that flash on the screen, maybe. And that's one good way. And then, of course, our website at UC Davis constantly has updates about the coronavirus and how to keep yourself safe. And that's probably the best way.
So, David, back to the coronavirus, COVID-19. I know UC Davis has a research wing or department. I don't know what you'd call that, and you can respond here in a second. But tell us about any work you guys are doing on therapeutics and or vaccine.
Right. So UC Davis is involved in, I think, 39 different studies right now around COVID-19, everything from studying the communities that are underserved, how to create a more equitable diagnostic and treatment plan, to actually being part of studies for remdesivir and vaccine trials. We're working at a very basic level in developing our own vaccine. A lot of people don't know a lot about UC Davis, it turns out, but next to the NIH itself, we do the second most animal studies in the United States.
Oh, wow.
And have a very robust system in order to test therapeutics and vaccines at the animal level before they get into humans. And as a matter of fact, remdesivir, the one drug we know that works, it was initially studied at the UC Davis School of Veterinary Medicine as a potential Ebola cure. Again, we have a long track record of dealing with pandemics, and we will employ all of our clinical and basic and animal model research to that end until we see this disease vanquished.
Quick question for you. The Department of Veterinary Medicine, is that under UC Davis Health?
No, that is part of UC Davis, the university. They are the #1 veterinary school of medicine in the world. And we join with them in something called One Health, where, the idea of the health of our planet, and meaning in our School of Agricultural and Environmental Sciences is part of this, and School of Veterinary Medicine, School of Human Medicine. We're all joined together doing some very large projects about how we keep our planet and all of its inhabitants and living things healthy.
Awesome, David. Very cool. Yeah, I never considered veterinary medicine being under health. And when you mentioned it, I'm like, wait, I better double check.
Again, if you've got a beloved pet or a large animal, that's the place to go in the United States of America.
Yeah, no, I bet. Cool, David. Well, I think we got some good content here, and really want to say it's a privilege, and I really appreciate the response on LinkedIn and your willingness to participate on short notice. Thanks, everyone, for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.